Dave Shields studied at Dana College and received a bachelor's degree in psychology and sociology. He began his career providing behavioral interventions to youth in a residential setting, which solidified his interest in assisting others overcome adversity in their lives. He moved forward in his career and began providing in-home counseling and skill development services to children and their families that had disruption to the cohesion of the family unit. In 2005, Mr. Shields had the opportunity to begin working with survivors of brain injuries and their families in a case management and administrative role. While functioning in this capacity, he earned the Certified Brain Injury Specialist designation from the American Academy for the Certification of Brain Injury Specialists, and later his certification as a Certified Brain Injury Specialist Trainer. Realizing that working directly with individuals was his passion, Mr. Shields furthered his education by earning a master's degree in human services and a master's degree in clinical counseling from Bellevue University. He has been employed with Community Neuro Rehab since 2010, providing community-based neurobehavioral rehabilitation. He has served in many roles in this organization and is currently the Director of Development. In addition, he has experience facilitating various support groups and serves as a board member at the Brain Injury Alliance of Iowa. So thank you all for participating today, and I will go ahead and let Dave get started. Thanks, Dave.
Thanks, Annie. And I just wanted to say thank you for giving me the opportunity to come and speak about substance abuse, mental health, and brain injury. We here at Community Neuro Rehab provide community-based neurobehavioral rehabilitation, and many of our participants struggle with this. So we'll do a quick overview of the training objectives, overview of common maladaptive coping mechanisms after brain injury. We're really going to look at causation for those coping mechanisms. Overview of supportive strategies to address those conditions, and going to discuss some barriers to support and maybe where we can find some support for those situations. In this presentation, I am going to talk about some basics, and then I'm going to move into two different tracks, some strategies for the survivor and strategies for the care or the support system or the professionals in order to better support the folks that we serve. So we'll talk about basic brain functions first. We all know that the brain is the control center for your entire body. We typically see these in 4 different areas, including physical areas. So we're talking about gait, we're talking about movement, digestion, all those different aspects of how our body moves and functions. Then cognitively, when we talk about cognition, we talk about thought process. Behavior and emotion. Behavior is how we interact with our environment, and finally psychosocial. And when we talk about psychosocial, we're talking about human interaction. And we must understand that after a significant brain injury, there will be either temporary and oftentimes permanent changes to one or all of these functions. Typically, what we see is a sequela of problems following brain injury that typically occurs over the spectrum. Before we get started in the specifics, I do want to take a second to get a full picture on rehab. And we need to look at rehab as a process. The picture is a young man that is a pitcher, and the Academy of Certified Brain Injury Specialists posed a scenario of a pitcher who breaks his arm. And what many people like to think in rehab is that you have a condition, you do physical therapy, occupational therapy, and speech therapy, and then at some point there's an ending to this process. And that might be true for somebody with a physical deficit like a broken arm. Now, even at that point, some people might argue that that broken arm is never the same, but that individual will have most likely full use of that arm. In brain injury rehab, it's really not that cut and dry. It may not have an ending point. These processes, once again, can be temporary, but most oftentimes, to one degree or another, they're permanent. Frequently, what you see is somebody going through a brain injury rehab, being successfully discharged, and then at some point along the way, needing a touch-up, coming in and doing more range of motion, or having orthotics adjusted, or coming up with different cognitive strategies. So we need to move from the concept of a starting and an ending point to a spectrum. While we see a lot of progress at the beginning, that will continue and it becomes a process. The second aspect that I want to talk about is the difference between restoration and compensation. Now, restoration is where we have some level of function that is lost, and then due to rehab processes, those skills come back in one way or another, they're restored. Compensation is at a certain point, restoration begins to wane, and we need to look at strategies to compensate for those deficits. And those are a lot of things that we try to focus on for long-term success. So moving forward, there is a new kind of catchphrase that we're seeing, and that is multi-occurring conditions. And when we talk about that, at least in the realm of brain injury, what we're talking about is that an individual has an acquired brain injury. Now, this is the definition of acquired brain injury in Iowa, and in my knowledge, in the Brain Injury Alliance and the Brain Injury Association. It's an injury that to the brain that is not hereditary, congenital, degenerative, or induced by birth trauma. We'll just look at that again. Hereditary means you inherited it. Congenital means that it occurred prior to birth. Degenerative is it gets worse over time, dementia processes per se, and of course birth trauma. Secondly, major mental health disorder. And this is any diagnosis that can be found within the DSM, or the Diagnostic and Statistical Manual, and it's one of those 18 categories, and there's many diagnoses within those categories. And then finally, issues with substance abuse, and that can either be addiction or substance misuse. And misuse is simply that you're using something in the way it wasn't intended, much like a painkiller or a benzodiazepine, where you might be prescribed those, but you use it in a way that it was never intended. So we'll talk about some maladaptive coping. And struggles can happen for any of various reasons. Lack of premorbid coping skills, and premorbidity means prior to the injury or prior to the condition. So if you had struggles in your life before your injury and you didn't have good coping skills, there's a high likelihood that you're not going to have miraculously developed better coping skills after your injury. We tend to return to those maladaptive behaviors. A lack of support system. Frequently, what we see in long-term disability is that support systems tend to fade away over time. And that can happen for many, many reasons, including just behavioral presentations, families and friends have to move on, go back to work. So without that support, many survivors have struggles. Unemployment is a big one. I'm going to talk about this more later, but when most people identify or self-identify, they often identify in what they do. And if we take that away, most people have a level of struggle. Financial stressors, and I'm sure this doesn't come to a surprise to anybody on this webinar, but long-term disability and brain injury is expensive in many ways. Most people have some level of employment, they have insurance, they have savings, they set forth a path in their life, and then they have a horrible day or a series of horrible days, and all those financial supports fade away, which can be very stressful. That can exacerbate mental health conditions, substance abuse issues. So that is a major stressor in somebody's life. The specific nature of the brain injury, and I'm going to get very specific on some of these, but there are a host of conditions after brain injury that promote maladaptive coping. Mental health problems. If folks have struggles with significant depression, anxiety, they're doing the best they can, and that does typically have consequences in coping. Substance abuse issues. When we're abusing substances, we're having struggles on many levels. And oftentimes, if we're abusing those substances, we're not coping well. That becomes our coping mechanism. Sorry, and not having meaning and purpose. So substance abuse, what we look at is the continued use of a substance despite health, psychological, or social consequences. Health consequences, many times there are significant health concerns with drug use, alcohol use. Psychological consequences are problems with support systems within the family, or social consequences. Those can be friends fading away, can be involvement with law. And typically we see when a substance is being used in a way it wasn't intended. Right now, our society is going through a problem with opioids and benzodiazepines. It's one of the major issues with addiction currently, and we're really struggling with that. So once again, it's something to be aware of. Substance abuse. Now, I am a certified brain injury trainer, and I took some of this information out of the current essential brain injury guide, and it's really eye-opening that approximately 2/3 of people receiving rehabilitation for brain injury have issues with substance abuse. We all know that substances dulls our senses, makes us disinhibited. A big issue is motor vehicle accidents. And once we have an injury and substance abuse, those individuals are 10 times more likely to go back to substance abuse than someone that didn't have abuse problems in the first place. So we're going to talk about some strategies to cope with multi-occurring conditions. The first is social capital. And social capital is a concept that you're involved with networks, that you have many different outlets with friends, clubs, recreation, and there's some level of reciprocity involved in that. So when I talk about social capital, I often say that your presence makes a difference in your community or in society in some way, or society would be a little worse off if you weren't there. So in other words, to develop better coping, go out and make friends and get connected to where you live. We talked about before how after long-term disability, support systems go away, which leads to social isolation, increases depression, most likely increases problems with substance abuse. And I know sometimes it's difficult to get out there and meet people, but it is essential that people get plugged in. From my experience at Community Neural Rehab, I see it as one of the biggest indicators of success. When people have social capital, they tend to be better adjusted. Another coping mechanism is having meaning and purpose. Touched on this earlier, is that many people identify as their job or life role. People identify as they were an accountant, they were an engineer, or I took care of my children. And if those things change, and for one reason or another, you're unable to return to that job or that life role, what happens? Well, most of the people feel disempowered. They don't feel like they have control of their life. They feel like people are telling them what to do all the time. They feel helpless, like things can't change, like they can't take control, and oftentimes feel hopeless. I frequently say that we have to find meaning and purpose. There has to be a reason to get out of bed. There has to be a reason to take a shower. There has to be a reason to treat people with respect. And if you don't have meaning and purpose in your life, you're going to have struggles with those aspects of life. So what we need to do is focus on possibility and potential. How can you give back to your community? Can you seek employment? Maybe it's different. And then supporting others who are experiencing what you've experienced. I really encourage people to volunteer, get a job, go to support groups to talk about what you have experienced, because many times people feel alone in their journey. And it's very powerful for people to identify, I'm not alone. Living healthy. Now, I talked about earlier that I'm an instructor, a trainer for the Academy of Certified Brain Injury Specialists, and I got some of this from them, but one of the things that they say about living healthy is get plenty of rest, which I agree with, but I want to tweak that a little bit and say develop a healthy sleep-wake cycle. Many times after brain injury, sleep-wake cycle gets disrupted, and we have to make very concerted effort to readjust. If we simply say get lots of rest, that is a problem with people that are depressed. So we want to make sure that we're sticking to a healthy sleep-wake cycle. Eat a balanced, nutritious diet that's varied in nature. This can be difficult as well when we look at the financial aspect of it, or maybe the ability of preparing meals. That might be difficult, but it's important for your overall wellness. Plenty of exercise to the ability that you can. We all know that there's physical consequences to brain injury. However, to whatever extent you can, get plenty of exercise. If that's going for a walk, at some point even standing can be exercise, cardiovascular exercise for people that are not mobile. Attend all medical appointments. Once again, I understand that some people struggle with social anxiety, and simply the thought of leaving the house can be overwhelming. However, it's important that we take care of our medical needs. And then finally, take medications as prescribed. Your physicians have ordered them for a reason, and we need to take them which they were intended. And once again, some of those can be abused, so we need to make sure that we're not contributing to substance abuse issues. Avoiding substances. Substance abuse causes impaired judgment and coordination and increases the chance of brain injuries. Some of you may be aware, but falls are the #1 cause of brain injury. And when we look at that in coordination with, say, alcohol intoxication, where you may have a slightly impaired balance and coordination in the first place due to your injury, and then you multiply that by including alcohol or other substances, you're more likely to have a fall. The next bullet should be alarming or awakening as well. And then that is basically, if you have an injury, you're 3 times more likely to have a second. And surprisingly, 8 times more likely to have a third. And whatever we can do to protect ourselves from that is very important. And then this next bullet is alcohol intoxication causes between 37 and 51% of brain injuries. Once again, falls, motor vehicle accidents, physical altercations. Substances can lower the seizure threshold. There's been lots of research that if you have a seizure disorder, you really should abstain from all controlled substances. We know that it can affect mental health conditions. Alcohol is a depressant. Some people think it's just a depressant when they drink, the whole tear in my beer aspect. However, it has long-term consequences over your mood. It interacts with medications in a way that some people may not be aware. It can either neutralize your medication or potentiate it, make it more potent. And then finally increase the chances of having interactions with law enforcement, which we want to avoid at all costs. We want to talk about relapse for a minute. And it's important to note that relapse is rarely spontaneous, meaning most people who have a level of sobriety under their belt don't just typically say, I'm going to go out and use. Typically speaking, there's some event, and I'll get into triggers in a little bit, but there's some event that makes you have some level of cognitive dissonance. And then that starts craving. I'm going to go back to my old maladaptive coping mechanisms. At this point, there's a level of planning, and relapse has already begun. You seek out the substance of your choice and use, and then finally there's the level of guilt. Now, I must say that relapse is conventionally seen as a part of recovery, and that is accurate. We need to make sure that we go into a learning mode that when it occurs, what's my trigger? What can I do to prevent that? Relapse prevention. People that have been around AA and NA might be aware of these. We need to avoid old playgrounds and old playmates. If we frequented bars for entertainment and we're trying to get sober, we probably don't want to go to bars. Moreover, our old drinking buddies are drinking buddies. They will most likely encourage us in one way or another, subconsciously or consciously, to relapse. Know your triggers. It may be a lot of things. It may be physical conditions, being tired, thirsty, hungry. It might be emotional conditions. Being lonely is a big one. People that are depressed, sad, and alone frequently use to make themselves feel better. Also, dates. Anniversaries of your injury are often a relapse trigger for many people, many survivors. Holidays. Holidays are a big relapse trigger. Seek support. Go to AANA. People need help. No man is an island. Stay away from toxic relationships. These are relationships that when you walk away, you feel drained. Those individuals can get you in a mindset, can be your trigger for relapse. Avoid people who enable you. And being enabled can happen in many, many ways. It can be providing you with a substance. It can be talking about old war stories about use. It can be making excuses for your use. And we need to be aware of those and stay away from those individuals. And finding new avenues for recreation. For many people, especially in rural Iowa, there's very little to do. Where the bar, the pub, becomes the center point of community, it's difficult to find other means of recreation, but it's important. We want to keep as many, keep the brain cells that you have and make as many more as you can. So this is just the reality about human existence is this neuronal atrophy happens. It's a normal part of aging. It speeds up as you get older. Unfortunately, in many cases, it speeds up after injury, but it can be combated, and it's combated by learning, by staying busy. Isolation and boredom increases this, so we need to make our brains busy. Talk about neuroplasticity. And neuroplasticity is basically, if you can see the picture in the bottom, if you can imagine your brain as a gigantic circuit board, and if one of those circuits get broken, your brain has the ability, in some cases, to rewire itself so that function can continue. Now, it might be different. It might look different, it might feel different, but that's the aspect of neuroplasticity. And the best way to utilize this ability is get into a learning state of mind, meaning try to think of different ways to do the same thing. I know in physical therapy, there is a method of restrained training. Basically, if you have had a stroke, a lot of times people struggle with hemiparesis, and they'll restrain your unaffected arm that forces you to use your affected arm. And basically what you're doing is utilizing the process of neuroplasticity. Now I'm going to split into the two tracks of how to support and utilize coping skills. And the first track I'm going to talk about is for the professionals. And the first thing I want to talk about is self-care. In this diagram, if you've ever been on a plane, we've all seen it. It's if an oxygen mask descends from the ceiling of a plane, what do? And of course, you put your oxygen mask on before you help others. Because if you're unconscious, you can't help anybody else. And that's much the same way in supporting folks in a helping relationship. If you don't care for yourself and you get burnt out, you'll be ineffective in helping the person that you really want to help. We need to, in order to help the folks that we're helping, we need to understand the specific nature of their injury. One thing that I want to talk about, and I was reflecting on this while I was developing this presentation, is I don't believe I've ever seen this bullet before, but I think it's important to say, is that people that have an acquired brain injury are not intellectually disabled. Simply put, is just because you've had an insult to your brain does not mean you've lost intelligence and should not be treated as such. I see this frequently, and I had another bullet initially that said, people that have an acquired brain injury are not hard of hearing, because I frequently see people that speak loudly or treat people as they're lower intelligence, and that's not the case. So we need to be aware of that. We need to understand changes related to cognition and memory. And this is very important, and I am going to spend some time on this one bullet, because this is things that I see that support systems and professionals struggle with the most. The first one being perseveration. When a survivor has struggles in getting stuck, and it can be one of many ways. It can be a cognitive sticking point where they think about the same thing over and over and over again. It can be verbal. They say the same thing over and over and over again, or it can be physical in nature. And frequently, support systems and families gets upset, tries to reorient them per se. And it's not a very effective strategy of interaction. So we need to understand, become an expert in that individual and what does work. And I can't sit right here on this webinar and tell you what will work for everybody. It's individualized. The second point is confabulation. Confabulation is a struggle for many people, especially people with short-term memory loss. And confabulation is having a lapse of memory, and then your brain, in the schema of which you have lived your life, creates a memory in place of that memory loss. Your brain does not like having gaps, so it will fill it in when possible. Now, many people believe that these individuals are lying, and they are not lying. It's a subconscious mechanism to help fill in the blank. Moreover, reorientation to confabulation is several things happen. Number one, the survivor feels that you're calling them a liar. Number two, it puts your relationship in a position of being combative in nature. And moreover, that person, generally speaking, what research has found, becomes more entrenched in the confabulation. So it's important to know what specifically that works with that individual. Reorientation and correcting that individual does not work. Short-term memory loss, for both survivors and support systems and providers, this is maybe one of the biggest struggles that people have. And there's lots of compensatory strategies. I could probably put on an hour-long presentation on that alone, but we once again have to figure out what works, what's innate with that individual. I tell the story all the time of an individual that I thought I could help with assistive technology. This individual carried his phone everywhere he went, and I thought it would be great if I put all of his medications in there and appointments, and so an alarm would go off for everything that he did. I came back several days later, and I asked to see his phone, and I observed that there was 57 ignored alerts. So that didn't work for him. It may work for somebody else, but for that individual, it didn't. Another problem area for many people is anosognosia, and this is a technical term from a lack of awareness of deficit. And once again, people want to reorient people to let people know what their deficits are, and it's ineffective. From a level of self-preservation, many other cognitive processes, that is not an effective technique. So I can tell you what works in some people, and some people it doesn't, but reorientation doesn't. Impulse control. Many times people feel like survivors with impulse control problems are doing things purposeful. Take, for example, you have somebody that walks into a store and they impulsively want to take something, and then they're deemed as stealing. They're not stealing, they have an impulse control problem. Now, I'm going to get into a little bit more later about the theory of no blame. And another problem people verbalize a significant amount of time is people that have struggles with expressing anger constructively. If you have poor impulse control, especially with frontal lobe injury and executive dysfunction, people frequently become verbally and physically aggressive, destroy property, maybe. So it's important to have appropriate interaction skills. There's a concept of no blame. And I'm going to talk about this a little bit, is that most providers, professionals, support systems would not blame an individual for a physical deficit after injury. If someone has hemiparesis or hemiplegia maybe and are unable to walk, we would think it would be absurd to say you need to get up out of that wheelchair and walk. However, most people, to one degree or another, have struggles with cognitive deficits after brain injury, impulse control, frustration management, memory deficits. But we need to understand that that person is no more in control of the cognitive deficits as the individual with physical deficits. Power and control. Another problem that I see a significant amount of time are people that feel like they need to control the survivor in one way or the other, that innately that the support system feels like they know what the survivor needs. And that typically causes there to be conflict. I say this all the time, I'm very open about it. I, to one degree or another, are a little oppositional defiant. And if most people truly search their soul, they'll see that as well. And if we expect that a person with cognitive deficits doesn't have that, we're wrong. So what we need to do is learn how to set limits for yourself versus setting limits for the individual that you're supporting. We need to understand the concept of systems. Nothing happens in a vacuum. So we need to understand, what are you bringing to the table? If you've had a hard day before you walk into work, are you bringing that to the interaction with somebody that may have explosive behavior? Are you enabling people because you don't want to be the bad guy, put up with whatever deficit it is? Then you're encouraging the behavior to occur. So we need to understand, for a level of self-awareness, of what are you bringing to the table so you can adjust that. And finally, this goes back to one of my first points, is the support system needs to understand how to interact with the survivor in a manner that produces positive outcomes. Many times after brain injury, remember, brain injury rehab is a process, okay? So we need to understand that sometimes success looks like the support system being the survivor's frontal lobe, or understanding how to interact with them to be early in addressing those struggles instead of being reactive. So this bullet, I want to talk about the concept of independence and interdependence. Now, most people, they say that they want to be independent, and what I'm here to tell us all is that the concept of independence is a cognitive distortion. It's not really a realism, and I'll demonstrate that by the movie Castaway. We're all social people. We need others to survive, and Mr. Wilson on the bottom of your screen is an excellent example of that. Tom Hanks's character hit somebody, and Wilson saved him on many occasions. And we need to understand that nobody is independent. We all function in systems. I'm dependent on the utility. I'm dependent on my family. I'm dependent on my friends, and that's okay. It's okay. We need to understand that these need to be positive and reciprocal, meaning when I walk into our rehab centers, I'm not a staff member. I have reciprocity with all the individuals that I work with, and it's positive. So we need to reconceptualize the thought of independence and think about more interdependence and each other's role in that relationship. One of the objectives is understanding barriers for multi-occurring disorders, knowing where to go get help. And the first one, going to give a shout out to the Brain Injury Alliance for neural resource facilitation, case consultation, and support groups. The neural resource facilitators are the experts in brain injury services in Iowa. If you need assistance in finding some resource, they are the people to call. For providers that are having struggles with interventions with individuals, they provide case consultations, and of course, the very important support groups that are statewide. NAMI, the National Alliance on Mental Illness, is very important for helping folks with peer support in support groups for mental health. Inpatient and outpatient substance abuse treatment for folks with substance abuse disorders, and of course, AA and NA, 12-step groups to help people with peer support. Brain injury specialty programs. Now, there's a number of brain injury specialty programs in the state of Iowa. Community neuro rehab being one of them. Each one of them are specifically designed to help a person throughout their travel or their journey in rehabilitation. There's all the way from post-acute rehabilitation to supported community living services. Psychiatry, neuropsychology, and mental health providers. Psychiatry is there to provide medication management. Neuropsychologists are important in understanding where deficits lie so people can address those issues, and then of course mental health providers. I wanted to leave some time, which is I have approximately 15 minutes to answer any questions that people may have.
Thank you, Dave. I'll go ahead and let people take a moment to go ahead and enter your questions now. And as you're doing that, I would just like to remind everyone to please reach out to the Brain Injury Alliance of Iowa if you are in need of any brain injury resources or information. Like Dave had said, our Neuro Resource Facilitation Program is designed to help connect anybody with a brain injury, along with their caregivers, their loved ones, and the professionals that are serving them to needed supports and services in their communities in Iowa. And we are also always available to provide any sort of case consultations to professionals. If you have a client with a brain injury and you are looking for more information or resources to help figure out what to do. And we are also available to provide general training on brain injury and our Neuro Resource Facilitation Program. So let me look at the questions here and see. No one has entered any questions. So you do have Dave's contact information up there. Like you said, reach out to him if you have questions. Oh, here's another one. Here's a question. Here we go. From Christina. If your loved one isn't wanting help, what do you do? Or how can you help someone who maybe doesn't want help?
That is a difficult question. From a provider standpoint, I tend to use motivational interviewing techniques or Socratic dialogue to help people increase their level of awareness. It may be difficult as a family, the main thing that I can say is allowing the individual the dignity of risk, not sheltering them from consequences for behavior. Without specifically understanding the nature of why an individual needs help, that's a very difficult question to answer.
I would agree. We have another question from Elizabeth. Besides depression and anxiety, which mental health issues most commonly occur with brain injury, or are those the main two?
Depression is by far the major struggle after injury. Depression and anxiety are close cousins. We see a whole host of diagnoses. Some of them are not necessarily appropriate, but we see folks with bipolar disorder. There's a new term for that in the realm of brain injury. I think it'd be more appropriate for pseudobulbar affective disorder, and that's mostly due to frontal lobe injury. We do have some level of people with psychosis. And then some people have struggles with cognitive rigidity after injury, so they may appear to be obsessive compulsive in nature. But once again, this is a soapbox that I tend to get on a little bit is appropriate diagnosis is important because medication management of those diagnoses are different for folks that have had injury. And I'll give an example. People that have problems with psychosis after injury, if an individual is given antipsychotics per se, that might increase behavior. Whereas after brain injury, people respond better to anticonvulsants like Depakote. So it's very important to understand the difference between premorbidity, mental health diagnosis, and comorbidity, or occurring due to the brain injury.
Thank you, Dave. Yeah, it's really important to highlight the topic of how meds interact differently after brain injury, and even if you don't have the right diagnosis, totally agree.
I will also say that it's important to have good history and good historians and documentation to ensure that the medical provider understands what medications are appropriate.
Correct. I don't think that we have any other questions at this time, so I will just refer everybody back to Dave's contact info and let him know if you have any further questions after the session. And just as a reminder, this webinar was recorded and will be saved on our YouTube page in the coming days. That channel on YouTube is just Brain Injury Alliance of Iowa. Your certificate of attendance will be emailed to you along with a link to a survey for your feedback on this webinar. And as a reminder, we have another webinar coming up on May 15th on the topic of supportive strategies for behavior changes in children after brain injury. So be sure to check that out and sign up for that one too. But I just want to thank you, Dave. Do you have anything else you'd like to add before wrapping up?
No, I just want to thank everybody for their time. And if you have any questions or I can be a support in any way, feel free to give me a call or email me.
All right. Thank you, Dave. And thank you, everyone, for being on today, and have a great rest of your day.